So we originally thought that this was our original title for our presentation because we figured everybody here wanted to know about some really complex statistics, but the CAN people said it'd be too boring for people here, so we decided to go with something slightly different. And so instead we'll be talking about this. We had our creatives punch up the title a little bit. And really what today is all about is really three different things. We're going to be talking about the gathering of data, how we display that data, and how we analyze it. Sometimes how we analyze it really appropriately, and sometimes how we do it inappropriately. Quick demonstration.
All right, so we have the opportunity right now to do the first live ever stepwise analysis at Khan. So can you all just stand up, please? Excellent. Okay, stay standing. That means don't sit down if you were here at least as of last night, say 5 in the afternoon. Okay, if you arrived this morning, you can sit down. All right, stay standing if a few, okay, we've lost a few in our cohort already. Our analysis is working. Stay standing if you have an American Express card. All right, a few more. All right. The fine and the few still standing. Stay standing if you had a little too much to drink last night.
I'll be honest.
All right. So our stepwise analysis has showed us that there is some probability that if you are attending Cannes Lions Health and you have an American Express card, you are at risk for abusing that and drinking too much. All right. So this is an example of how we can use or abuse statistics in the creative work that we do. And statistics is basically about relationships. And the way we use it in our line of work is using descriptive statistics, what we see and what we observe, to help us derive predictive statistics, what we will see or what we should see. But we don't always get it right. So if I take a euro coin, which I have here somewhere, and off stage while I was listening to the other presentations, I'm flipping the coin, and I flipped it 99 times. And each of those 99 times it comes up heads. And if I flip it again, can you tell me what the probability is that it's going to come up heads again? Flipped it 99 times, I'm going to flip it the last to make 100. Always heads. Come on, someone in the audience, be brave. 50, excellent. It's always going to be 50%. I only have 2 chances here. But in our line of work, we're sort of introducing other factors that may affect what our chances are. And we can sometimes sort of lose sight of what those factors impact in terms of our true risk. We tend to be concentrated on things like this. What's my chances of being killed by a shark? Oh God, another plane went down. That could have been me. I fly a lot for travel. The agency's always sending me everywhere. I should be worried about that. Or certainly Ebola, we were pretty focused on it once we started worrying about some of those contracted cases arriving in the US. But what statistics helps us do is put all of that news into context and understand what our real risks are. 25% chance that I'm going to die of heart disease someday. So we hope you're going to learn a little bit about data, and when the talk is over, please tell us what you felt about it.
All right, so data. So we're all about collecting data and big data. So we've had the year of mobile in the past. This is the year of big data. It will be probably for the next 5 years, just like it was the year of mobile for a really long time. So data is not always what it seems. It's not always hugely beneficial. Sometimes they're just numbers. So I'll give you an example. So how many people are carrying something that tracks a number of steps that they take? All right? And there's this magical number of 10,000 steps, right, as a goal to get to. But really that's just a goal that's kind of been thrown out there, but it may not be right for you, it may not be right for somebody else. For somebody else it may be quite a bit less. For somebody else it may be quite a bit more. And so it's really just a number. I could just easily have said, hey, I have 4 chickens. Well, is that good or bad? Well, it's bad if yesterday I had 1,000 chickens and now I only have 4. But if I had no chickens yesterday and I have 4, that's probably pretty good. This is going to be the newly released Chickbit app. I'm still working on the name a little bit. So what you really want to know with the 10,000 steps is, what if I did 10,000 more? Or, hey, since I did all that exercise, can I eat a bunch of bacon today? Or really, did I improve my mortality? And that's really what the question is. So what does a number actually mean for me and applying it to myself? The challenge that we have now, as opposed to say 4 or 5 years ago, isn't collecting the data. We've got plenty of data. We can collect a ton of things about this guy, but can we actually apply it to his individual health? So what this might look like, picture kind of individualizing this. We all know the risks of cigarette smoking. We know that it causes a ton of preventable disease, ton of preventable deaths, but the trick is applying it to myself. So pretend there's this new Apple Watch app that keeps track of each time we smoke a cigarette, and we know that, hey, every time I do that, I reduce my lifespan by 7 minutes, 8 minutes, 9 minutes, depending on who you ask. So if every time I smoke, I get a little alert on my wrist that says, hey, here's how much time you've lost this month, and it's individualized to me, that's probably going to make more of an impact than just saying, hey, I smoked 20 cigarettes today. So individualizing that is really the key. One of the other things that we do that we're guilty of is using pictures to, well, we don't really mean to lie, but it ends up as a lie. And so one of the ways that related to that is that we kind of confuse this. We think that correlation, two things that move in relation to each other, is the same as causation. And we all know they're not the same thing, right? Let me give you a little example. So, and this is the most statistically thing we'll get, so bear with me. So, two events on here, we got the black line and the red line, and there's this R coefficient, right, which shows how closely correlated something is. So one thing goes up by 1, the other thing goes up by 1, or one thing goes up by 1, the other thing goes down by 1. That would be a correlation of 1. So this is a correlation of 0.94, which is really, really close, and you can see by those lines. So what you'd say is like, wow, whatever that black thing is, it means it's causing the red thing, or vice versa. So here's what these lines actually are. The red line is the per capita consumption of cheese in the US, and the black line is the number of people that die by getting tangled in their bed sheets. In the US, we're a little clumsier. So what this would lead to is, I don't know, some device that was attached to your sheets that detected if you ate too much cheese, or like a really menacing warning label on a package of cheese that says, caution, you're at risk for dying in your bed sheets tonight by consuming this entire package. Or, I mentioned inverse correlation, here's what that is. So, as more juveniles are arrested for possession of marijuana, there's a decrease in honeybee colonies, and we all know that there's a problem with losing honeybee colonies, right? So what we should do as a public policy is legalize marijuana for juveniles to rebuild the honeybee population. That's what happens when we confuse correlation and causation. When it applies to healthcare, we get something like this. So we've all heard of cancer clusters, right? Where individual cancers are occurring at kind of a high degree of frequency in different areas. And we can plot this on a map. And let's say the red dots on this map are cancers, the blue dots are other households. So we go, wow, look at around that river there seems to be a lot of cancers that are happening. That's kind of unusual. And we realize, hey, it's actually really isolated into this area. And so we dig up some research about the river, because clearly that's what has to be causing it, right? And we find out in the distant past that a bunch of really bad chemicals were dumped in that river, and we say, gosh, we got to clean up that river because it's causing all these cancers. And so, we have this battle to figure out whatever this thing is. And right, there's a hashtag for it. We have like a TV special. Bruce Springsteen writes a song about it. Kanye West says something really outrageous. And we battle against this thing, right? And then when we figure it out, we're like, hey, we cured cancer. Everything's good. Until you realize causation and correlation aren't the same thing. So the real cause of all those cancers, if you look and go, wow, actually, all those cancer dots also are these dots too. And it turns out that, hey, that's actually just all the old people are right there. Because we know that old age is causal with cancer mortality. And so the real reason why all those cancers popped up is because a bunch of old people live there and they don't want to move. Not that there's something horrible in the river. So we have to be really careful about how we interpret statistics and how we interpret the data. And as creatives and strategic folks, that's one of our jobs.
Something else that we always need to be really smart and attentive to is the delta between absolute difference and relative difference. And I think all of us in this room have done some sort of promotional or informational material where we are told to report, here's the difference, and make sure you're using the relative difference. And that's basically because relative difference makes it feel like a big impact. Here's some data from a treatment for coronary artery disease, and if you took the treatment, your risk of having a coronary event, a heart attack, stroke, dying from the event was reduced by 36%. 36% if I were a physician, I'm gonna get out my script pad, I'm gonna go onto my EHR, all my patients who are at risk for any one of those events is gonna be prescribed this. But this risk reduction is only relative to the other group, the people who are dying. If I look at what my risk reduction is in the actual population, which we're trying to represent, it actually doesn't look that different. 1.5 people to only 3 people who suffered the event. So that's when things like shark spray start to look good and might be actually a better investment of the money. Here's a drug we've probably all worked on, Curadol. Fantastic drug, again, showing that it reduces the risk of stroke by a very large margin in these patients. And the reason why that risk reduction is so big is because we've chosen to use the relative risk, right? We're looking at that risk reduction, not in regards to the whole population, but only to the people who were in that specific trial. And then we're gonna play a little game and we're gonna decide, but wait a minute, with side effects, we can report just the absolute reduction. And so it makes that number actually quite small. If instead we use the inverse of those statistics and we decide that we're going to report the true value of the risk reduction, well then the change in our treatment intervention doesn't look so appealing and all of us lose our jobs. When we apply what the relative risk reduction would look in terms of side effects of taking that drug, then our risk of experiencing any of those side effects goes up to 100%. You know, I don't want any of us to lose our job, actually. I think it's statistics that helps keep us employed. And so we just want to be mindful. And if you ever have a question about it, you know, send us a message, call your strat planner or your local bias statistician to figure it out for you. Something else we sometimes get confused by is the hazard ratio. When we see a hazard ratio coming in, and the symbol typically looks like this in a group analysis, and we all back away because we think it's an incoming drone of data, and that's something that we're a little bit uncomfortable with. And when we start to then populate all the subgroup data, it looks a little bit confusing, and we think, well, we don't really know if this drug is good for anybody. But the hazard ratio is very simple, it's quite clear-cut, and almost telegraphically communicates information for healthcare providers and to patients. So the line down the middle right here is 1. And if I'm at 1, this is how my risk for a disease or my potential benefit for an intervention stands. It's stasis, it's just 1. If something that I do is going to increase my risk, it's going to be over to this side of the 1. So if my hazard ratio is 2, it's doubling my risk. That might be based on my age, it might be based on my gender, it could be based on getting diagnosed a little bit later. If something decreases my risk, so if my hazard ratio is below 1, 0.7, 0.5, it's actually cutting my risk in half. And I would beg you to please push for these in your creative communication efforts, because this is a fantastic way for a healthcare provider to personalize data from a very large trial in discussions with their individual patients to say why losing weight or why being persistent with a certain drug really addresses what their personal risk factors are.
So that's she's like the good witch, I'm the evil witch. So if you want to do it the bad way, of course, we can do it really easily with charts, right? So I'm not going to accuse anybody necessarily, but has anybody made a chart that looks like this before? Yes. Has anybody made a chart that looks like this before? Note the scale on the left, ranging from 3.1 to 2.7, but showing what appears to be a tremendous difference between our two drugs. Had I made the scale more legit, how would it look? Again, cast me out of the pharma community, and my chart looks like this not so overwhelming version. So keep an eye out, because now more and more people are going to look for that sneaky little trick. So So as we said, gathering the data is not a challenge. There's a ton of it out there. There's actually so much we don't even know what to do with it. What we don't want to do with it is the wrong types of things. We don't want to interpret it in ways that are going to confuse patients. We don't want to interpret it in ways that are going to make us choose the wrong types of things. And as we go forward, if you think it's quote unquote bad now, it only gets worse. So more and more data is going to be out there. More and more pieces of collectibles and data trackers are going to be available. More electronic health records are going to be available. And that's good, but there's also potential risk for it.
So the NIH, and they're being joined by several research institutions around the globe, has created this VD2K because, Y2K is done, and so we need something new to look forward to in this millennium. And the big data to knowledge will see tens of millions of dollars invested in improving patient outcomes and understanding what are the best ways and the most efficient and least costly ways to realize those gains in patient wellness. As you can see from our visual here, your attention is drawn to the big blue part of the pie, which is pretty much where we work in disease education, disease incidence, disease amelioration, and interventions with devices, with prevention, with healthy habits. And there are nearly 50,000 clinical trials that are open right now or opening right now. And what does that mean for all of us? It means more data and more statistical analysis. We know certainly in the US and following the lead that's happening in a lot of other countries for decades that our healthcare decisions are being more and more based on demonstrable improvement in outcomes. And that's all driven by really the best understanding of statistics. So we're going to ask you to get a little bit involved in this and understand what your opportunity is.
All right, so the title of the presentation, for those who saw it in the beginning, was Lies, Damn Lies, and Statistics, which I'm sure you've all seen before. And so now, after seeing all that horrible stuff that can be done with statistics, which nobody's ever done in this room, he said, kind of questioning, what I want to do now is say, okay, who's going to do the right thing now with statistics? So pledge to no longer do the evil thing, so you can either go onto this little mini website we set up, send out a tweet with this hashtag, no lies, no damns, get it? Lies, damn lies, you got it, you're a smart bunch. Go and make that pledge that says, hey, I'm not going to be evil with statistics anymore, feel free to be slightly more creative than that, and there'll be some wonderful prize. Actually, there's no prize, it's a total lie with statistics. 52% of you will get a prize, you won't get anything. All right, so you can find us on Twitter there and all of our contact information. Also, you can download the slides of this presentation if you'd like to spread the word from this website as well. Thank you very much for your time. What's that?
They got a woo. Thank you very much to Jonathan and Amy from Sadler.